before we talk about the results, Dr. Pela, in your actual study, the actual paper, you have a literature review that gets into some important points there. So before we get into the results, like, okay, the potential for harm from this type of therapy and the chances of effectiveness, one of the things you did in your literature review was talk about the potential for harm in therapy in general. And how effective therapy in general is. And that sort of gives us a context. When we talk about, oh, safety is harmful. Well, compared to what? Is therapy itself harmful? So could you provide a little bit of the data there that was in your literature review regarding the risks within therapy in general?
Right. Yeah. So this has been a suggestion. Actually, it was in a paper that Dr. Christopher Rossick had written, where he said, we can't talk about harm in this kind of therapy for this particular population with these particular goals if we don't do it in the context of what you're saying, harm in general in psychotherapy. And there's been quite a bit of research done on that, even though people don't like to talk about it. But probably 6 to 10% of people fall within that. It depends on the study, but generally that's a good range. 6 to 10% of people going to therapy experience harm to one degree or another. It can be more just like, it's just not effective. It doesn't really help. It's just a waste of time, to actually feeling some trauma as a result. I just talked to somebody last week that had experienced trauma, like actually had to go to therapy with someone else after having therapy with a gay affirmative therapist. But that's a whole different story. And so it happens in regardless of the approach. And, there's all kinds of research about why that happens and what sets you up for success as a therapist of not being harmful. And really one of the key things, and I had to cut this out of my lit review to make it shorter, but there's this whole body of literature that demonstrates that promotion of self-determination and autonomy of the client is the best way to protect them from harm.
Yeah, I want to get into it because you brought up in the conference, the digital conference or the online conference we did. You did get into it for a bit, but let me just get it back to the risks in therapy in general. Some of the things I remember from when you were presenting your study at the conference was that about 45% of clients coming to therapy for depression experienced no change, like no real benefit. If this was widely known that nearly half of the clients coming to counseling for depression will receive no benefit from it, we would probably be storming all the therapist's office and saying, you're a bunch of frauds and crooks and swindlers here.
Or we should ban people from seeking help for their depression. We shouldn't allow people to seek help for depression. And then we should have laws against that.
Yeah, if we're going to be consistent here, why don't we just ban therapy as a practice in general? It's all a bunch of quackery.
Right.
3 to 10% of clients for therapy in general, for other non-same-sex attraction issues, experience clinical deterioration. So not just no benefit, but actually get worse. So that's just in therapy in general. So when we talk about the potential of harm for safety, we have to put it in terms of that light, that already 3 to 10% of clients going to therapy in general will get worse. Okay. So what are some of the elements that you found in your literature review that makes therapy more effective and more beneficial and increasing well-being?
Yeah, it's interesting. This research it was started by Carl Rogers, looking at the difference that makes the difference, and the therapeutic alliance is the key. And now they're narrowing it down. Well, what about the therapy? How do you, what are the elements of a good therapist who's going to do that? And then, so the self-determination and autonomy, the support of that, the centering the values of the client, the agenda of the client, not your own agenda, so really respecting their boundaries. And there are a lot of little things too that are considered important in creating that therapeutic alliance. And there are great measures out there for therapeutic alliance. In fact, the OQ 45.2 has a TA, a therapeutic alliance version, where you can
Okay.
also measure that. And a lot of therapists use that and other measures to make sure that they're establishing that therapeutic alliance, because that even the therapeutic alliance in and of itself will influence change toward the client's goals.
Yeah, one of the things you mentioned in that conference was that 25% of poor results from therapy are associated with a lack of support for the client's self-determination.
Yeah. And I think that's the research that was done by the gay affirmative therapists on gay affirmative therapy. It's the Israel folks and what's the another group that did really looking at LGBT clients in particular, and they're particularly sensitive to being seen as a whole person, not making it all about their sexual attraction.
Yes.
It's really important to do that. And that's what I love about what the Breakthrough Clinic is doing. And
so you're telling me that clients didn't come into the office and you, Dr. Nicolosi, you didn't just go there and tell them what they should think about their sexual attractions and their behavior, and you impose something on them. Like this.
No, right. It's client-led. The client-led therapies are shown to be the most powerful. The client gets to pick what they want to work on. The client's in the driver's seat of their own therapy.
Exactly.
And that's what's most important. And so it's almost like a Montessori method of trauma treatment. What do you want to work on? Whatever that is, okay, let's explore it. Let's see what emotional dynamics are behind it. And then we integrate that with the trauma treatment. And so we're fusing that with the concept that it is client-led. I mean, the highest rated therapies are evidence-based, data-driven, and client-led. And we need this kind of robust research in order for the public to know which therapies meet these thresholds.
Okay. So that's the context that we already are doing this research in, and we're going to get the results. What did we actually find? Dr. Pela, let's start with the risk of harm. What were the results that we found?
Yeah, I don't have the numbers in front of me, but what we found is a statistically significant increase in well-being. The instrument, the higher the number, the more distress that the client is experiencing. And so we had a statistically significant drop in distress. In fact, these men were at a level that we would find just a regular person on the street, we wouldn't expect for them to be in therapy. So, but when they left, they were ready to be finished with therapy. So they weren't at a clinic, they were well below the clinical level. When they started, they were above the clinical level of distress. The other thing that's interesting about this is there's a reliable change index for most instruments and the reliable change index shows that if the client change is this number, in terms of points, number, like literally a number, and if it exceeds that, or it meets that or exceeds that difference, so their high to their low exceeds this difference, it means that it's a lasting and a reliable change. And so as an average, they exceeded that number. So we had reliable both a clinical and a statistical difference. And it's pretty, and you know what, I could see the raw data, right? So as it's coming in, I could see the raw data. That change happened very fast. Honestly.
Yeah, that's interesting. But before we get into it, let me just give a little data on the OQ45. It gives people a score from 0 to 180, and that's measuring well-being, or rather non-well-being, because the higher the number, the greater distress.
Right.
And so the cutoff would be 63. So if 63 and above would be clinical distress of some sort. Okay. Pre-test, I believe this is the data you gave us at the report, was the average or the mean was 71.27.
Yeah.
So there are a few deviations above that 63 there.
Right.
And the final post-test, which I believe was at 24 months, so about most of them was about 2 years,
Yeah.
was 54.56. So below
Way below.
the,
Mhm.
yep, you had a nice wiggle room there. It was below the point of it being clinically significant, any distress they were
Yeah,
experiencing.
clinical distress. Yeah. Yeah. Yeah.